this episode of The Donut of Destiny, hosts Sotirios Evangelou and Nisha Hosadurg sit down with guest Alan Vainrib to explore how computational fluid dynamics is reshaping the way clinicians understand structural heart disease. The conversation delves into how CT and MRI-based anatomical models enable CFD to simulate pressures, velocities, shear stress, and post-procedure hemodynamics, offering fresh insight for evaluating aortic stenosis, planning TAVR, and guiding mitral, tricuspid, and LAAO interventions. Sotirios, take it away.
Hello, I'm Dr. Sotirios Evangelou, a consultant cardiologist from the Balkan Medical Center of Thessaloniki, Greece. And today, in this Donut of Destiny episode, we are taking a dive into the intriguing field of computational fluid dynamics in structural heart disease, with co-host Dr. Nisha Hosadurg and guest Dr. Alan Vainrib. Please, Nisha and Alan, can you introduce yourselves?
Yes, thanks, Sotirios. I'm Nisha Hosadurg. I'm a multimodality cardiac imager at the University of Virginia and a member of FSCCT's first committee. Happy to be on the show today with Sotirios and with our guest, Alan, who's also, I'm happy to be a member on the first committee with, and I'm glad to be learning about this relatively new topic to me.
Thank you so much for having me. I'm Alan Vainrib, Director of Structural Heart Imaging at NYU Langone Health. My clinical work focuses on CT and echocardiography for structural heart interventions. And over the past few years, I've become increasingly interested in how advanced computational tools, particularly computational fluid dynamics, may eventually deepen our understanding of valve physiology and device performance.
Perfect. So, computational fluid dynamics nowadays is a well-established technique used in many fields of engineering, design, and analysis. It is a technique that uses computer simulations to analyze systems involving fluid flow, heat transfer, and associated phenomena. Computational fluid dynamics is suitable for a wide range of industrial and non-industrial applications, including, for example, aircraft and automotive aerodynamics, but in cardiovascular field is usually utilized to analyze blood flow patterns within the heart and vessels by considering physical laws governing fluids, and while coronary computed tomography and angiography-based computational fluid dynamics has been widely employed nowadays to address various clinical and physiologic problems, since, for example, CCTA-derived FFR enables the non-invasive evaluation of the functional significance of stenosis, less is known about current applications in structural heart diseases.
Indeed. Computational fluid dynamics can potentially help the evaluation of cardiac pathophysiology beyond just coronary evaluation, such as in aortic stenosis, potentially predicting complications of TAVR, planning left atrial appendage occlusion, and potentially a variety of other transcatheter valvular interventions, it seems, and even congenital applications like tetralogy of Fallot evaluation. So, Alan, could you describe for us the main principles of computational fluid dynamics in the context of structural heart interventions?
Of course. CFD in structural heart disease is still early, I want to point out, almost entirely in the research and preclinical space. But we're seeing extremely promising foundational work coming from engineering groups such as Georgia Tech and industry R&D teams within companies like Medtronic, who use CFD to study device behavior and procedural risks well before we ever step into the hybrid OR. So basically, CFD is a physics-based simulation method that takes high-resolution anatomical data, either from CT or MRI, and uses mathematical modeling to estimate how blood might flow through a specific anatomy. Where CT gives us anatomy and echo gives us measured velocities along a beam, CFD gives us full three-dimensional predicted fluid behavior through the cardiac cycle. So the typical workflow includes first segmentation, where you isolate the chambers, valves, sinuses, coronaries, and surrounding structures. Then you do mesh generation, which converts that anatomy into millions of computational elements. Then you set boundary conditions, assigning physiologic inflow-outflow assumptions, and then you perform numerical solving, running the Navier-Stokes equations to model pressures, velocities, shear stress, and vortex formation. Right now, this is performed in engineering environments, but conceptually, it offers a richer, more physiologic layer of information on top of our imaging.
Great. And what about the main quantities of interest, Alan?
So CFD allows us to interrogate fluid behavior at a level that traditional imaging may not reach. So in research settings, we can analyze velocity fields throughout the entire domain, not limited to Doppler alignment. We can simulate jet structure and dispersion, including eccentricity and temporal evolution. We can simulate recirculation or stagnation zones that are relevant to the potential for thrombosis, and importantly, sinus washout. We can simulate wall shear stress patterns, important for leaflet stress and device fatigue. We can predict hemodynamics after virtual device implantation, which can help us understand how flow might change with different valve sizes or positions. Again, these are not clinical tools yet, but they provide deep mechanistic insight into valve-device interactions.
Great. Thank you, Alan. So the whole world of the sort of CT-based physiologic modeling, other than for coronary flow, to me at least, is quite new. In the past year, we've had the ESC come out with a comprehensive guideline on the management of valvular heart disease. There's also a multi-societal guideline spearheaded by the FSCCT describing CT and prosthetic heart valve assessment. So, and you very much rightly highlighted that the CFD for structural valvular interventions is quite new, but I guess in the context of current guidelines, do you see these techniques fitting in, and where can it sort of provide the most value? It's like in aortic stenosis, other things. What are your thoughts on that?
Yeah, I think relative to the recent guidelines released in August of 2025, I think aortic stenosis is probably one of the most promising areas for future CFD application. One key potential advantage is the ability to simulate and predict flow velocity patterns through a stenotic valve. So essentially, rather than a single Doppler velocity, you get a full 3D map of how fast blood accelerates across the valve. And then you can also simulate how the jet eccentricity is and where it impinges on the aortic wall. And this can be helpful in anatomies where Doppler is difficult because the jet is eccentric and you can't align with it on echo. And another area of interest, maybe potentially related to these guidelines, is TAVR planning. Essentially, one of the focuses of those guidelines was talking about using CT for halt. And essentially, CFD can simulate how a particular valve size or implant depth might redirect flow, alter gradients, and change, very importantly, the sinus washout. And we know, essentially, that is very, very important for essentially avoiding halt in these patients. And so CFD can essentially provide a physiologic preview of what the hemodynamics might look like after implantation. And again, sort of overarching, we're not using this clinically today, but it shows what a personalized physiology-driven planning could look like in the future.
And what about analysis of mitral valve regurgitation, Alan? Do you believe that is it useful prior to transcatheter therapies? And, for example, in particular, issues such as LVOT obstruction?
The mitral valve is incredibly complex. There's a dynamic annulus, there's many jets that could be oblique. The devices that you put in there are pretty large. So CFD has definitely generated significant interest here. For MR, CFD has the potential to provide three-dimensional jet geometry, sort of capturing how it expands, spirals, or divides within the left atrium. This may eventually help characterize severity or atrial loading in ways potentially Doppler can't. For TMVR, I think the most powerful application is dynamic LVOT modeling. Instead of relying on a solely static neo-LVOT measurement, CFD can show us how the flow accelerates through the LVOT during systole. It can show us if there are vortices or flow separations, can show leaflet displacement, and essentially how different implant depths can affect the outflow tract. So it can definitely provide more information than simply that our traditional neo-LVOT would provide.
Yeah, that's very interesting. Thanks for expanding on that, Alan. It does seem like in a bulk of the data that we have on, or again, which is still fairly limited on the utility of CFD, is in aortic valve planning or post-procedure like complication prediction. Is there much value of it in, say, other structural heart disease interventions like tricuspid, left atrial appendage occlusions, or like congenital structural interventions or planning?
Yeah, I mean, for me, outside of aortic and mitral disease, I think CFD, essentially there are two areas that sort of stand out to me. One is left atrial appendage occlusion, as you said, Nisha. For left atrial appendage occlusion, it's basically really about flow. And essentially the goal is to eliminate areas of slow blood movement that predisposed to thrombus. And CFD can simulate washout and identify residual stagnation zones around a implanted device. I mean, that was one of the advantages of it, is that we can use our CT data set and put a virtual device in there and then simulate flow around that device. And this could be potentially useful in very complex appendage anatomies with multiple lobes or chicken wings and all of these. And essentially, we can help predict either paradevice leak or which anatomies are at a higher risk of forming device-related thrombus. And the other, I think, area that this is potentially could be useful for is in transcatheter tricuspid repair or replacements. I mean, the right heart is a very low pressure, low velocity system with complex inflow patterns from the IVC and the SVC. So CFD can visualize how these inflows interact with the large tricuspid replacement frames or altered leaflet geometries after edge-to-edge repair. It may help us one day identify areas of stagnation behind a prosthesis and potentially predict a risk for thrombosis on that device.
Perfect. And what about validation in this field, Alan?
Yeah, I mean, I think validation is probably the most important aspect of this. I mean, CFD simulations need to be compared against real physiologic measurements before they can move toward clinical relevance. Right now, validation can be done using comparisons with invasive catheterization, directly measuring the pressures and gradients, 4D flow MRI potentially, and then, of course, echocardiography. And echo is particularly important because it remains our most accessible and trusted real-time physiologic tool. And essentially, because Doppler gives us such great velocities, CFD really only gives us predicted ones. So we need to do more research to validate these predicted velocities against actual velocities. And I think that is the source of very, very ongoing research. I mean, right now, echo is the standard and CFD is trying to complement it. But for CFD to progress, we need standardized modeling assumptions, reproducible boundary conditions, and multi-center validation.
Great. Thanks, Alan. I think that's very well said. And just overall, you've really nicely highlighted the utility of this technique and how clinically helpful it can be. But what sort of technical challenges are there to actually clinically implementing this and maintaining a consistent quality of data in everyday practice, or even if it's limited to expert centers? Are there specific scanner platforms or acquisition protocols that we need to use? And then also, what, if any, assumptions are we making when we're using these Navier-Stokes or other equations, and how can they potentially cause variability in the results?
Yeah, I mean, I think in terms of the scanner protocols, I think what we need to do is to certainly make sure that the data that's acquired is the highest quality, because essentially CFD fully relies on having a very, very high quality, essentially CT, so that we can apply the model. And, for CFD, there's a lot of significant challenges. One, segmentation and meshing that are central to it. It's just still right now very labor intensive and requires a lot of expertise, and essentially which is sort of keeping it in the research realm. There's performed by people with engineering backgrounds. You mentioned boundary conditions. They really vary widely, and it's hard we don't have a standard because each one is set by the performing institution who's doing it. So it's certainly a standard for boundary conditions is going to be very, very important. Right now, the computational demands are massively high, essentially, for these models. I mean, you really need like a supercomputer to get these things to work. The clinical translation of it is still not quite there. I think once we have more validation, I think it will become much more of a practical use. And we don't really have any standardized workflow platforms that integrate this kind of technology with our CTs or echoes at this time. And so right now it's still a very research topic, but I think there's so much potential for the future with CFD.
Yeah, no, that all makes a lot of sense. And you kind of alluded to this already, but despite somewhat limitations that we have now, where do you think the future of using computational fluid dynamics in valve disease is heading? Is it a situation where potentially in the future it might save the patient a trip to the cath lab for getting invasive hemodynamics? Is that kind of our goal with this technique, or are there other sort of things in mind that you have?
Yeah, I mean, I think the future is really potentially very exciting. I mean, CTs are very, very widely used. We have them, and to be able to apply a computational tool to a CT to get information about flow velocity and hemodynamics would be extraordinarily promising. I mean, look at the impact of HeartFlow and other programs that use CFD to model flow through coronaries. I mean, we could potentially be doing those kinds of things on CTs for valves as well. But I think some future directions that make me optimistic about this technology are essentially implementing more automation, so that we need that to streamline the segmentations and then automatically apply modeling. Right now, extraordinarily hot topic is artificial intelligence or machine learning, and those technologies and those advances could potentially be used for CFD to reduce computational time, which currently is hours to days to seconds. And then we could potentially have what they call patient-specific digital twins, essentially a virtual heart where you can test multiple devices before choosing one. And I think we're going to need improved engineering clinical collaborations to bring this to fruition.
Well, nice point, Alan. So can you share an example from your clinical practice where CFD altered or influenced the management approach?
Absolutely. One memorable case I had was essentially a patient with a degenerative core valve who was being evaluated for a core valve and core valve procedure. I mean, these situations can be super, super challenging because putting a core valve inside of a core valve really elevates the supraannular leaflets towards the coronary ostia or aorta and potential risks coronary obstruction. So we generated a patient-specific CFD model to better understand how blood might flow around the coronaries, and essentially really helped reassure that there would be flow on the outside of the core valve and that we would not obstruct the coronaries. So it's a really neat potential for essentially device selection and predicting what can happen in some complex redo TAVR situations.
Perfect. So, Alan, I think that you described thoroughly the aspects of implementation of CFD in the field of structural heart diseases and giving us useful insights. So, thank you for that, Alan.
Yes, absolutely. I agree with that. Thanks so much for a wonderful review of this topic. Just highlights another exciting direction that CT has the potential for.
Yeah, thank you so much. It's really an honor and a pleasure to join you guys and to talk about this.